Hi, everyone. Welcome to the Epilepsy Foundation of Connecticut webinar on psychogenic non-epileptic seizures. Our presenter today is Dr. Lorna Meyers, Director of the Psychogenic Non-Epileptic Seizures Program at the Northeast Regional Epilepsy Group in New Jersey. We are happy to be able to present you with this opportunity to learn more about a topic that is unknown by many people, including professionals. So we're grateful to Dr. Meyers for being here, and just to let everyone know, you are in listen-only mode, so please, any questions you have, go ahead and type them at any time, and we will get to them at the end. Okay, thank you, Dr. Meyers.
Okay, thank you. So today we're going to be talking about psychogenic non-epileptic seizures. For short, we call them PNES. I'm the director of the PNES Diagnostic and Treatment Program at Northeast Regional Epilepsy Group, and we have been working with this type of disorder for over 15 years at this point, or at least I have been working with that disorder for over 15 years. So the first question is, what are psychogenic non-epileptic seizures? And this is a lengthy definition, but I've underlined some of the more important things. Psychogenic non-epileptic seizures are experiential and behavioral episodes that superficially resemble an epileptic seizure but aren't produced by abnormal electrical discharges in the brain. Instead, they represent a psychological condition that is often misdiagnosed as epilepsy, and they are a form of dissociative response to emotional triggers. So that's a lot of psychobabble. But basically, when someone has a psychogenic seizure, they may either experience different sensations or exhibit different behaviors that look a lot like an epileptic seizure, but they are not triggered by abnormal electrical discharges in the brain. Instead, they are triggered by emotional factors. And the other issue is that they are very often misdiagnosed as epilepsy. We'll talk about that more in a bit. There are two different types of non-epileptic attacks, essentially. Physiological non-epileptic seizures can be due to syncope, low blood sugar, sleep disorders, migraines, etc. That is not what we're going to be talking about today. We're going to be talking about the psychological or emotional non-epileptic seizures. And psychological or emotional non-epileptic seizures are episodes that are triggered by psychological distress, and very important to keep in mind that this distress is not always conscious. And further, it can be fueled by depression, anxiety, anger, difficulties with reading emotions, and very often a trauma history. And we'll be talking a little bit more about this as we continue. A lot of times I get the question of how can someone's mind be doing something that they don't know about? And in extreme conditions, what we know is that the brain can activate and deactivate parts of itself. Dissociation, or a splitting off of awareness, is one such feature that can happen, and it happens during PNES. So the brain basically may perceive preconsciously something that is distressing, and that is perceived preconsciously before you are actually fully aware of that. This is called pre-attentive emotional processing. Your neurons finish processing an event half a second before the information is processed. Reaches your conscious brain. So, for example, if you're talking to someone and their body language or their tone of voice or the topic that was just brought up is deemed by your brain as distressing or as some form of threat, that might trigger an intense emotional response without you even being aware of that. And that produces very often a dissociative response where the brain splits off from itself. And you will see that during PNES there is an alteration in your consciousness where you might still be somewhat aware of what's going on around you, but you cannot respond, or things look different than they normally would. So there are a number of challenges with PNES. The primary one, I would say, is that it overlaps two different specialties, neurology and psychology/psychiatry. And very often it falls between the cracks. The question is always, is this a neurological problem or is this a mental health problem? And it creates a ping-pong effect where patients are seen by neurology, sent to psychiatry, or psychology, sent back to neurology, and back and forth like a ping-pong. The reality is that this is a mental health problem, but neurology does need to be involved in the initial diagnostic process. So it does become a team approach when you're dealing with PNES. Oops. So PNES falls within the scope of neurology because this medical specialty is involved in making the diagnosis, but it falls outside the scope of treatment of neurology because it is psychological. Now, inpatient epilepsy monitoring centers throughout the U.S. evaluate and diagnose around 20 to 30% of their inpatients with PNES. So it is a relatively common problem within neurology and within epilepsy centers, and it is encountered with relative frequency. The problem, and I put it in red because it's very important, is that very often patients are discharged without a referral to a mental health professional. So they're given the diagnosis, you don't have epilepsy, you have psychogenic non-epileptic seizures, you should look for psych help, but the patient is not actually given a referral. We did a survey a few months ago on our website. The website is non-epilepticseizures.com. And the question was, when you were first given the diagnosis of PNES, did you also receive, or if you were given more than one, pick the one that was most useful for you? And there was a series of possibilities. 27% of the respondents said that they had been given the name of a psychologist or a psychiatrist, which is fantastic. But 32% had been given nothing other than the diagnosis, other than the name. And this is not necessarily the neurologist's fault. I can tell you that many neurologists are desperate to find good mental health referrals where they can send their patients. And there has been a lot of work with subcommittees of people who are professionals who are working specifically with PNES in trying to determine how either a referral database could be created or some way in which we can make that connection between neurology and mental health and provide those referrals to those patients who are being diagnosed. Another issue, though, is that even when the patient finds a psychotherapist, there are still other obstacles. Many psychotherapists think that PNES is outside of their scope of practice because they see it as a neurological issue. They are not familiar with the diagnosis, and when a psychogenic seizure occurs in the office, the diagnosis is often questioned and the patient is sent back to neurology. However, the only treatment for PNES, if that is the correct diagnosis, psychogenic non-epileptic seizures, is psychological and psychiatric. And this is the second obstacle that we have to fix. We need to educate mental health professionals so that they know what PNES is, so that they know that they are prepared to treat this, and so that they know which treatments have been studied the most and that they can implement. Just very quickly, what's the right way to call this disorder? I call it psychogenic non-epileptic seizures, PNES. The second name that you're going to see on this page, pseudo-seizures, is a very outdated term. It should really not be used anymore. The problem with the word pseudo is that it can mean fake, and there's nothing fake about these seizures. They are not epileptic, but they are very real. These are behaviors and experiences that can be very disabling, There can be injuries as a result of psychogenic seizures, et cetera, et cetera. So the term pseudo-seizure ends up being pejorative and can sometimes affect the relationship between the health provider and the patient. If the provider in some way doubts that these are real seizures, in quotations. There are other names for this. The other name that I also like is non-epileptic attack disorder, which is what is used in the UK. And I would say that there's a new term that's been popping up, dissociative seizures. Again, I like it. I think it's descriptive. It's not pejorative. So those are some of the terms that we prefer. Question, what does PNES look like? And it can look very much like an epileptic seizure. It can have a whole variety of presentations. Shaking, paralysis, inability to speak, groaning, clenching. Duration is typically short, but it can vary. Auras, which are sensations or signals that the seizure is about to start. Sometimes someone will report either smelling something or feeling something in their stomach or feeling something in their head prior to the seizure. Can also be present. Movements of the entire body or parts of the body can be present. There can be injuries as a result of the seizures. Typically, there is some semi-consciousness, so some degree of consciousness is preserved. Speech may or may not be present, and there can be urinary incontinence during these episodes. So they can be very similar to epileptic seizures and hard to distinguish just by looking at them. So how do you diagnose PNES? Just by visual observation and history taking, you can very easily get a false positive. Same goes with a routine office EEG. The gold standard for diagnosing is using a video EEG monitoring unit and test. The professionals who read these tests and who make the determination regarding epilepsy versus PNES are neurologists, epileptologists for the most part, with board certifications in the American Board of Psychiatry and Neurology, American Board of Clinical Neurophysiology. And if you have a child who has this condition or that you suspect has this condition, you would typically look for a pediatric epileptologist. You see here that there is a website, aesnet.org, where you can click to find an epilepsy center or an epilepsy doctor using your zip code. And you'll see that there is something called the NIAC Level 3 and Level 4 centers. These are centers that have been evaluated and are found to be to have the necessary staff, equipment, etc., to do some of the highest level diagnosing and treatment in epilepsy. What's an EEG? We'll go over this quickly, but typically 10 to 20 cables are attached to the patient's scalp, and this allows the doctor to monitor the electrical activity of the brain for a specified period of time. Video EEG is very similar. The only difference is that a video camera has been added to the procedure. The length of the study is usually extended anywhere from an average of 3 to 5 days, but this can vary. Usually the patient is well, obviously not usually, the patient is inpatient. There are a whole series of security procedures in place in case a seizure occurs. And this allows the doctors to look at the behavior during the episode as well as the brain waves, and allows them to make the diagnosis. If you are having difficulty having an episode in the hospital, doctors can use different kinds of approaches withdrawal of your anti-epileptic medication if you're taking it when you come into the hospital, hyperventilation, stimulation with lights, and sometimes suggestion, which is through speaking to the patient, seeing if a seizure can be provoked. How many people have PNES? I'm really going to focus in on the last line, which is that PNES is believed to be as prevalent as multiple sclerosis. So most of us have heard about multiple sclerosis, and I think it's generally a known concept in the lay public. But psychogenic non-epileptic seizures are not, and just as was mentioned in my introduction, even professionals do not know what PNES is. So that's on us, that we need to get the word out and educate the lay public, professionals, patients, etc. about this condition. How long does it take to diagnose and treat? And this number is very discouraging. It takes on average 7 years to correctly diagnose the condition, but it can be up to 16 years or 20 years. I sometimes receive emails from patients who have had the condition over 20 years prior to being correctly diagnosed. It's often misdiagnosed as epilepsy, so patients can suffer unnecessary side effects of medications, anti-epileptic medications. And there is a report that came out recently that patients can even die due to incorrect medical treatment, going to emergency rooms and having procedures done that would be typically done for epilepsy, and epilepsy that is not responding can lead to either injury or death of someone who has PNES and is being treated for epilepsy. It is more common among women. 6 to 7 out of every 10 individuals who develop PNES are women. We are seeing more PNES, more incidence of PNES in war veterans and in the elderly. But the most common age to start in adults ranges from around the 20s to the 30s. But there have been reports of very young children who have PNES. I should mention PNES in children is somewhat different. There's often family dynamics involved that are not involved in adults. Obviously, the importance of school environment, bullying, etc., learning problems can play a role, which is different than in adults. Can you have PNES in epilepsy? And yes, there are a fair number of patients who have PNES and who also have epilepsy. Depending on the report you look at, anywhere between 4 to 20% of patients with PNES also have some form of epilepsy. And probably the more accurate number is around 10% of patients with PNES also have epilepsy. And again, it underscores the importance of a video EEG, because if the diagnosis is both of PNES and epilepsy, you are going to need treatment for the epilepsy as well as the PNES, and they are very different. Can you have PNES if you've had a head injury? Is another common question. And yes, many patients with PNES report head injuries, and about a third have had a moderate head injury. There's ongoing research at our center that identified about 40% of a small sample had an abnormality on imaging, either on CAT scan or MRI. And head injuries may result in problems with self-regulation and inhibition that lowers the threshold for psychogenic seizures. So this is a hypothesis that's being bandied around, that it might be in this manner that a head injury goes along and perhaps even produces the psychogenic seizures or produces the necessary ingredients for psychogenic seizures. How common is it to have a family history of epilepsy? There is some research that suggests that 3 to 4 out of every 10 people with PNES report that someone in their family has epilepsy. And it is not uncommon that patients with PNES have also witnessed seizures at some point in their lifetime. Now we're going to talk about some of the issues that go along with PNES, some of the psychological problems that are seen together with PNES. And I mentioned first trauma and PTSD because there are reports of anywhere from 70 to 90% of patients with PNES have a traumatic history. This will vary depending on the study that you look at, but for decades now, any study that has looked at the incidence of trauma within a PNES population sees that it is elevated. And it is elevated compared to the general population. It is not uncommon to see sexual and physical abuse, bullying, psychological abuse, major losses, major illnesses or surgical procedures, or witnessing the abuse of another. And these are some of the more common reported traumas. PTSD and PNES, so the two diagnoses, depending on what report you look at, will go anywhere from around 25% to 100%. This basically means that you'll see in a sample of patients with PNES that they also have PTSD in anywhere from 25 to 100% of those patients. Now, does everyone who has PNES have trauma or PTSD? No. And again, depending on the study you look at, somewhere around 20 to 25% of patients with PNES deny any trauma. And of all those who've been traumatized, a smaller percentage goes on to develop PTSD. So not everyone who experiences trauma goes on to develop post-traumatic stress disorder, which is a very serious condition and which is independent of PNES and needs to be treated as well. So for those who have experienced trauma and who have PTSD, there are specific treatments available. And those who have no history of trauma and have PNES are still not well understood, but there are treatments available as well, in particular cognitive behavioral treatments that don't necessarily focus on anything traumatic that occurred, but rather on the current symptoms. PNES is also often accompanied by depression, and depending on the study you look at, you'll see that anywhere from 50 to 90% of patients with PNES also have clinical depression. Quality of life in PNES is significantly worse than the general population, but also in several studies it has been shown that quality of life is worse than even in those who have intractable epileptic seizures. So very serious epilepsy compared to PNES, quality of life in PNES is worse. Anxiety and PNES, the percentage of patients with PNES who are also clinically anxious is around 50%. And we know that there can be issues with stress coping strategies that add to the anxiety patients are feeling. This is something that you can work on in therapy and you can target. But definitely anxiety is very often hand in hand with PNES. Anger and PNES, often what we see is that assertiveness is missing in patients who have this disorder. And with a lack of assertiveness comes a feeling of being steamrolled. What can happen is that there can be numerous instances where the patient feels in some way mistreated or abused but doesn't respond, and at some point there may be an angry outburst that emerges. So typically patients will describe that they tend to be very nice and calm and tolerant, but from time to time have an angry outburst. And this is due to the imbalance between assertiveness and being able to set limits with others. Again, this is a treatment target. Emotional blindness in PNES, we call it alexithymia, the inability to read your emotions. In over a third of PNES patients that were looked at in a publication in 2013, we found that patients had alexithymia, which basically just means not really being sure what it is you're feeling or being able to put it into words. So having some sort of odd sensation in your body, but not knowing or not being able to say, I'm feeling anger, I'm feeling sadness, etc. Again, this is a target for treatment. And now let's shift into treating PNES. The first step, and it'll seem like a silly first step, but it's very important, is the conversation that the patient has with his or her neurologist or psychologist or psychiatrist prior to being discharged from the hospital. The explanation needs to be thorough, clear. The doctor needs to make sure that the patient, and if their family is involved, their family understands what this is. What is it? What do we know about it? Where does it originate from? How does it fit with the patient's history? And how can it be treated? And ideally, the patient doesn't leave the hospital without a psychological referral in hand. And next, the most successful psychological or psychiatric interventions are those that are integrated within the epilepsy center. So the transition is smooth, going from the inpatient unit directly to either a psychologist or psychiatrist or other form of psychotherapist who works within the same center and who's part of the team. So in other words, the psychologist or psychiatrist is part of that center, or is not, but is perhaps located in a different geographical part of the city, but works as part of a team. And in that way, the patient continues to be treated by professionals who are familiar with the disorder and who are colleagues of the patient's epilepsy specialist, and who can then be involved in any medication or treatment changes that take place. So that's in an ideal world. That doesn't always happen, but there are many other options available. So we talk about the ideal world, and then in the real world, there may not be a psychologist or a psychiatrist on staff, but as long as the mental health professional who is available is knowledgeable about PNES, is aware that this is a psychological condition, and is aware that there are some forms of treatment that have been studied and there are reports that are looking promising, then that's a positive as well. So until recently, there was no treatment designed specifically for PNES. I remember 15 years ago when I started to see patients with this disorder, doing a literature review and finding absolutely nothing. But there are now several treatment options that are available. And the goal is always elimination of seizures or a significant reduction in numbers. And what has been reported is that in anywhere from 1/4 to over 1/2 of cases, using some form of the treatment approaches that we're going to talk about in a bit, there has been this goal achieved, either elimination or significant reduction in numbers. You may hear significant reduction in numbers, and that doesn't sound like the goal that you have in mind, but what we are sometimes talking about is patients who have perhaps up to 50 seizures in a day, and then have a significant reduction in numbers, meaning that they go from having 50 seizures a day to perhaps having 1 seizure a week. And that is a very significant reduction and makes a very big change in that patient's life, even though the seizures are not completely eliminated. And I do want to note, not all treatments are helpful to all. Some of the short-term treatments may not be sufficient for those who have severe psychological disorders. for example, complex trauma or certain personality disorders. And long-term treatment will be necessary in those cases. So just to remind you, the treatments we're talking about are really targeting the psychogenic seizures. And I often say to patients, we have one goal, which is to treat your psychogenic seizures and to get them under control. But if there are other psychological conditions, major depression, anxiety disorders, etc., it will be necessary to continue with treatment once you have your seizures under control. And there are worse things in life than to go once a week and spend an hour talking about yourself and talking about issues and having someone who can bounce back ideas and who's paying complete attention to what you're presenting. So we said psychotherapy is the indicated mode of treatment once the diagnosis of PNES has been made. And there is scientific evidence and reports that some of the following treatments can be useful and effective. I have put them in no particular order. Psychodynamic therapy, mindfulness-based therapy, cognitive behavioral therapy, which you may hear called CBT, prolonged exposure therapy, EMDR, eye movement desensitization, eye movement. I'm blanking on the last two letters. Reprogramming. So there, you may hear a series of different types of treatments that are mentioned, and all of these have been studied to a certain degree, some more than others, and all are showing in these reports that they have the potential to be effective. I mentioned one last thing, which is psychoeducational group interventions, and then we go on to talk about psychodynamic therapy for PNES. This is the longer form of treatment that we were talking about. The goal of the psychodynamic therapy is to bring unconscious material to the surface, and you're going to produce change through insight. The psychogenic symptoms are seen as the result of a traumatic event or memory from childhood, typically, that's maintained at an unconscious level through many different defense mechanisms, and the seizures basically represent this distressing emotion being turned into physical symptoms. So rather than feeling the negative emotion, it gets converted into a physical symptom, and through insight is how you would work to produce the reduction in seizures. And I will mention psychodynamic therapy is very hard to study. There are only a few studies that I know of that have looked at this treatment and looked at the effectiveness of it, but they have found that a decent number of patients have improved using a form of psychodynamic therapy. Cognitive behavioral treatments for PNES. Cognitive behavioral treatments are the most studied treatments at this point. Partly they are easier to study. They can be manualized, and they are time limited. And basically CBT operates on current maladaptive thoughts, behaviors, and feelings, seeking to produce healthy changes. So it's going to target core beliefs that you have of yourself and of others and of the future through different interventions. And dysfunctional thoughts or behaviors related in some way to the conversion symptoms are going to be challenged, and they're going to be changed. CBT, like I said, is the psychotherapeutic approach that has been reported to have the highest level of efficacy evidence at this time for PNES, and there are multiple studies conducted in the US as well as the UK and in other parts of Europe that are showing that CBT can be very helpful and very useful in treating PNES. I don't want to go into detail. This is one particular study by Kurt LaFrance basically showing that cognitive behavioral informed psychotherapy, which is what he calls it, and CBT, IP with an antidepressant, both produced some very good results in terms of seizure frequency and in terms of other measures that they were looking at: depression, anxiety, quality of life, and global functioning. Now, for those who have PNES and PTSD, there is a very effective treatment for post-traumatic stress disorder that was developed by Dr. Edna Foa. It consists of 12 to 15 sessions, and the theory behind this treatment is that when we experience extreme trauma, we learn that in order to remain safe, many dangers in life need to be avoided. So avoidance becomes a big part of the survivor's life. And psychogenic seizures can be considered an extreme avoidance behavior to distress. So often there will be a trigger of some sort, and the seizure occurs, and that can be seen as an avoidance mechanism. So the treatment is to stop avoiding and to start confronting what you're afraid of, and to learn new responses to distress. So if a seizure occurs during the actual session, it is taken care of, and then the session continues, rather than what happens many times where session is cut short immediately after having a seizure. And we have a growing body of research that is showing that prolonged exposure, is effective in treating not just PTSD, the post-traumatic stress disorder, but also the psychogenic seizures, as well as producing improvements in depression. And what we did see in a recent publication that came out is that when we did follow-up at anywhere from a month to up to 36 months, depending on the patient, the gains made on the final session were maintained. Eye movement and desensitization processing, EMDR. There has been one report on this particular type of treatment in PNES. It looks very promising. We need more research on this, but it would make a lot of sense that just like prolonged exposure is helpful with the PTSD and PNES combination, EMDR might also be just as helpful. Mindfulness-based treatments. Mindfulness involves being aware of moment to moment of your subjective conscious experiences, so basically being aware of how you're feeling, what you're thinking, being in the here and now. You can become much more of an expert in mindfulness through regular practice of meditative practices. It helps you to improve attention, as well as emotional regulation, as well as body awareness, and all of these are key targets in a disorder such as PNES. So again, it makes a lot of sense that this type of treatment might be effective in treating PNES. Gaston BASLET and his group have published 2 articles on this, and I know that they're continuing their work on it. And like I said, it's looking very promising. But one thing is that one size does not fit all, and I like to say this. It's very important for the treating professional to carefully understand each individual patient, and often to tailor the treatment to the specific target points that the patient is presenting. So it requires that the therapist is flexible. So basically what I'm saying is that not every single patient might respond to prolonged exposure, or not every single patient will respond to mindfulness. It will depend on the symptoms that are being brought in. It'll depend on the personality of the patient. It'll depend on whether this is the right time and the right match. So a lot of this has to do with the therapist's ability to, one, evaluate, and to be flexible. So there are future directions that are, like I said, looking very positive. There is research into treatment options, including research continuing on CBT treatment models. In the UK, there's a huge research project underway assessing the effectiveness of CBT. There's also research underway for prolonged exposure for patients diagnosed with PNES and PTSD. There is research into mindfulness-based techniques. So what I want to say with this is that there's a lot of work being done, and sometimes it can feel to patients like there's very little being done, there's very little out there, there's not enough information, and then there are all these obstacles, but there is work being done, and we are definitely looking at, one, ways to improve the education of the health professionals, to make the seamlessness of the diagnosis to the treatment be present. And two, there's a lot of work being done on treatment modalities to see what exactly works with whom and what modifications may need to be made. But we're looking for an effective form of treatment for PNES. Now, what could help from the community's side? I encourage the PNES community to make its voice heard, and we should be uniting forces between health professionals, patients, loved ones, and advocates. It is urgent to educate the mental health professionals so that they know what PNES is and how to treat it, and the PNES community is urged to participate in research when it becomes available, when there's a call for volunteers. That would be a good time to consider whether you might be a good candidate and consider participating in that research. There are a number of resources now. There used to not be that many resources, but like I mentioned, we have a website, non-epilepticseizures.com. I write a blog about once a month, which is that address there. I just basically spout out about anything that I've encountered or has caught my attention regarding PNES. I also have a Facebook page where I post news and upcoming events. There is a way to find an epileptologist locally by going to this other website, the NIAC website. And there are treatment sites, not that many. I think 18 states are represented right now on this first website that I mentioned, where you can look for referral sites and see, based on your state, whether there is a therapist who specializes or has an interest in PNES. There are a number of books. I wrote a book a few years ago, Psychogenic Non-Epileptic Seizures, a guide. It's in English, Spanish, and Japanese. There's a fantastic book called View from the Floor, Psychogenic Non-Epileptic Seizures, A Patient's Perspective. There's In Our Own Words, Stories of Those Living with, Learning from, and Overcoming PNES. I co-authored it with Mary Marderos, and it is basically a book of testimonials. Often patients with PNES feel like they're the only odd duck who has this condition, and the book was basically done so that patients could read other people's stories and see how similar a lot of the stories are. There is Taking Control of Your Seizures by LaFrance and his co-authors. He has written two books. One is a workbook for patients and one is a book for professionals. And there's also a book on Kindle, Lowering the Shield, Overcoming Psychogenic Non-Epileptic Seizures by John Doherty. This was the first book that came out on PNES. It's written from a spouse's perspective, and he shares all of the struggles as well as things that worked for them in trying to find treatment and recovery from PNES. So thank you for attending this webinar. I know I've spoken at a million words a minute, but I thought that we were short in time. I thought we only had 45 minutes, and I was trying to get all of that information in there. So I hope it wasn't too much.
Thank you, Dr. Meyers. And we do have a few questions. I'll start with the first, which is asking, to those who are suffering with both PNES and PTSD, which do you recommend getting treated first, the PNES or the PTSD, such as seeking out trauma therapy?
Excellent question. I would recommend getting both treated at the same time. Like I was saying, prolonged exposure therapy is a PTSD treatment, so is EMDR, and they target the PTSD symptoms, but can very easily also target the psychogenic seizures with some very slight modifications. So the only thing would be to have a therapist who is trained in treating PTSD and make sure that there are slight modifications made in the sessions or made in the treatment that also then allow the PNES to be targeted. Like I said, PNES is basically another avoidance mechanism, which is very common in PTSD, and so this is one other symptom that the therapist is going to be targeting. Typically, the one big modification you're going to make in treatment for, let's say you're applying a PTSD-based treatment, one, you're going to want the patient to keep a seizure log so that you can see what triggers there were during the week. But also, you're just going to make some slight modifications for in the event that a seizure occurs in the office. I did a webinar a few years ago, and it's on YouTube, which is Psychogenic Non-Epileptic Seizures: What a Psychologist Needs to Know. And I recommend a lot of times that psychologists or therapists watch it because it just basically goes over the slight modifications that you can make, but you can still use all of the PTSD-based therapies, just like you would with a regular PTSD patient.
Okay, another. Are there visible differences in the brain, in a brain that doesn't have PNES as opposed to one that does? And if so, what are the defining differences? Is one more susceptible to PNES?
Yeah, this is still in very early stages where there are some studies being conducted to look at the brain of patients with PNES. And there are some initial reports that there may be differences in the functioning of the brain, but I would say we still need a lot of research before we can say anything like that. Clearly, there's been research on the PTSD brain, and there's growing evidence that there are changes that are produced as a result of the trauma, especially if it's trauma early on in life and if it's prolonged. So I wouldn't be surprised that we also see differences in PNES brain, to call it that.
We've had several questions of people asking, apparently a lot of doctors, it seems, they're not referring people to psychologists, and so we're having people ask the question, what do I do if my doctor is unable to help me to locate a professional that can provide the right treatment or who may know about PNES? So I know someone from Alabama asked that question, and then somebody else too. I don't know if you have other tips outside of what you've listed here on your presentation for people.
Yeah, I do. I typically, say, obviously, first you would go to non-epilepticseizures.com and see if that, if your state is represented, and if you have someone who's, just fortunately in your city, for example, and there are a number of therapists who are listed there. Other than that, I recommend going to APA, the APA.org, I believe it is. It's the American Psychological Association. If you Google it, it'll pop up. And they have a search for psychologist or find a psychologist option. What I recommend to patients is to type in, you won't find conversion disorder and you won't find psychogenic non-epileptic seizures when you look for a specialty, but you can look for trauma if that is what is part of your history, or you can look for dissociative disorders. And if the therapist is listed as specializing in dissociative disorders, then that is a good bet that that therapist can work with PNES as well. You may need to educate the therapist. That's the other thing, which is very irritating. But you can either speak very quickly with them on the phone and explain, PNES is definitely a psychological condition and it is a dissociative type disorder, and you can always refer them to either some of the literature that I just mentioned or the webinars and so forth. Yeah, but dissociative disorders or trauma are good ways to start, good specializations to start with.
Okay, so just one more here. I guess this is related to driving, and a question about, is it common for people with PNES to have their license taken away, and is there a different process for someone to get their license back than with epileptic seizures?
This is the third rail. It depends on the state, and it depends on the physician. And I will say, though, that the primary issue is always, should be in all of our minds, your safety and the public safety. So if you have a psychogenic episode, even if it's not an epileptic seizure, where you lose either consciousness, or you have a very severe alteration of consciousness, or you have a loss of control of your body, it can be just as dangerous to drive as having an epileptic seizure and driving. So it depends partly on what your seizures are like, when they tend to occur, but bottom line, it will depend on the state law and on your physician, and really on your own sense of wanting to maintain yourself safe and maintain everyone else safe, because a vehicle can be a very dangerous thing if you lose your ability to control your body, or you lose your ability to control your awareness. Okay, so that's a non-answer. Sorry, but that it's basically case by case, state by state, and doctor by doctor, and et cetera, et cetera. So there's no one answer to give.
Okay, so we just we'll do one more here, and this is on SE therapy, somatic experiencing. I guess they're wondering if you have found that to be helpful, or if you have any input about that.
All I can say is that I am not aware of any research that has looked at SE as a form of treatment for PNES. So it's not to say that it's not helpful, but I just am not aware of any research that has shown that it is or isn't effective. And I try to stick with the treatments that have a body of literature that has been looking at the treatment and measuring improvements and so forth. Okay, so there's a series of, there are actually a few therapies that are out there that I hear anecdotally from patients that have been helpful, but I'm just sticking today with those therapies that have research and publications backing them up.
Okay, well, thank you, Dr. Meyers. I see that you have your email address on there, so if people have further questions that have not been answered, they can utilize that's on here. Is that correct?
That's correct. And I'll only mention, sometimes I get bombarded by emails, sometimes I don't. So you know, when I am getting bombarded, don't be surprised if it takes me a few days to respond, because sometimes I'll get an angry email a day later that I haven't responded, and it's just that I've been busy. I haven't forgotten, but I also like to take time to respond, so you know, just bear with me. If I haven't responded in a week, then feel free to send me another email, just you know, nudging me, or perhaps somehow it got lost. So that's what I would say.
Okay.
Okay.
Thank you very much for taking your time to help shed some light on this subject, and we are hoping that this will be one step in the process of us helping our state here in Connecticut to know more, to learn more, and hopefully we can become a part of this, you know, movement to let this be a little bit more known than what it is now. So we are recording. This has been recorded, so for people can share the link with other people. You can go to epilepsyct.com and you can find that recording by the end of the week. So thank you, everyone,
for doing this. The Epilepsy Foundation of Connecticut. You know, I think it's fantastic that you've offered this webinar.
Thank you, and thank you to everyone for joining us today.
Okay. Bye-bye.
Bye.